Inflammatory disorders of bones and joints. The general features of inflammatory process includes void features, celsus features such as rubor, tumor, calor, dolor, and functional lesa, and also the central zone and peripheral zone. Inflammatory disorders of bones and joints based on groups. First group is the specific infection such as osteomyelitis, septic arthritis, tenosynovitis, and tuberculous. Second group is the non-specific and idiopathic inflammatory types of rheumatic disease such as rheumatic fever, transient synovitis, rheumatoid arthritis, ankylosing spondylitis. The third group is the inflammation secondary to chemical irritant such as metabolic arthritis or gout. Fourth group is the chronic inflammation caused by repeated physical injury such as chronic repetitive strain injury, for example, bursitis, Hematogenous tenosins. Pyogenic bacterial infections. It is a serious threat to both life and the limb. For the therapeutic approach is chemotherapeutic and antibiotic drugs, and also as for the clinical manifestation of infection may be masked. Acute hematogenous osteomyelitis. The incidence. At the beginning of era of specific antibiotic, sharp fall of the incidence. However, subsequently the incidence returned almost to its former level because the emergence of resistant strains of bacteria and failure of too many clinicians to understand and apply the principles of antibacterial and surgical therapy. Primarily, it is a disease of growing bones, with boys in much higher incidence than girls. Frequently involve femur, tibia, humerus, radius, ulna, and fibula. It could also involve the metaphyseal region. The etiology of acute hematogenous osteomyelitis is 90% Staphylococcus aureus. Portal of entry is skin secondary to infected scratches, abrasions, pimples, or boils. In the presence of bacteremia, local trauma seems to play a significant role in determining the bone. Higher incidence in boys and lower extremities. It could also cause by Streptococcus or pneumococcus, sometimes in infant. and it could also caused by Haemophilus influenza. However, it has almost been eradicated due to vaccine. The pathogenesis and pathology: initially small focus of bacterial inflammation, early hyperemia and edema in the cancellous bone and marrow of metaphysis. Bone is a rigid closed space, therefore a sharp rise in intraosseous pressure result in severe and constant local pain. It could also exaggerated by pus formation, compromise of local circulation, and result in vascular thrombosis and necrosis of bone. The untreated infections rapidly spreads to several routes by osteolysis. Damage vessels at local lesion, invade the bloodstream, result in septicemia. Local spread by direct extension, increased local pressure. Therefore, it could penetrate the thin cortex of the metaphysis and involve periosteum, result in exquisite local tenderness. The periosteum loosely attached during childhood, separated and elevated in the subperiosteal abscess, may be localized or spread around the entire shaft of the bone. The separation and elevation of the periosteum disrupts the blood supply to the underlying cortex, increasing the extent of bone necrosis. After the first few days, the infection penetrates the periosteum, results in cellulitis, and therefore there is a soft tissue abscess. There is also local spread to medullary cavity, extensive bone formation from elevated periosteum. The epiphyseal plate usually acts as a barrier if it's a damage result in growth disturbance. If it is uncontrolled, the septicemia may produce metastatic foci of infection in other bones or lungs and brain. Clinical features and diagnosis of acute hematogenous osteomyelitis is 50%. There is a history of local injury in children. Pre-existing bacterial infection in the skin or upper respiratory tract, severe and constant pain, exquisite local tenderness. Within 24 hours, there is malaise, anorexia, and fever, soft tissue swelling, radiographic changes after the first few days, and after the first week, there is an evidence of destruction of bone in metaphysis and reactive bone formation. To diagnose the acute hematogenous osteomyelitis, there is a radiographic changes after the first week, so we could use bone scan and MRI. For infants, the systemic manifestations are less apparent. White blood cells and ESR usually elevated, blood culture only positive in 50% of the patient. The systemic manifestation may be masked due to antibiotic. In the early stages, must be differentiated from rheumatic fever, cellulitis of soft tissue, local trauma to soft tissue or bone. After the first few weeks or more, differentiate from Langerhans cells, histiocytosis, Ewing sarcoma, and also osteosarcoma. Treatment is first with antibiotics, or oral or IV for 3 to 4 weeks, using penicillin, cloxacillin, or cephalosporin. There is also bed rest and analgesic or supportive therapy such as IV fluid, local arrest of the extremity by splint or traction, and if there is no improvement in 24 hours, surgical decompression may be needed. For the prognosis, the time interval between the onset of infection and the institution of treatment, ideally within the first 3 days the lesion is not yet ischemic. The effectiveness of the antibacterial drug against the specific causative bacteria. The dosage of the antibacterial drug. The duration of antibacterial therapy will determine the prognosis of the disease progression. Complication. Early complication result in death and abscess and septic arthritis. For the late complication, chronic osteomyelitis, pathological fracture, joint contracture, and local growth disturbance. Chronic hematogenous osteomyelitis. This is due to inadequate treatment of acute hematogenous phase. There is persistent and recurrent form. The incidence is high due to frequent failure to diagnose acute phase and failure to give appropriate treatment. Pathogenesis and pathology is the infected dead bone, therefore bacteria are able to survive in sequestrum. Surrounding point of pus prevent revascularization. It must be removed either by cloaca from involucrum and sinus or sequestrectomy. Area of persistent infection within cancellous bone walled by fibrous tissue, there is a Brogie's abscess. Clinical features: no longer acutely ill. There is a residual painful lesion, swelling, tenderness, loss of function of the limb, and one or more sinuses. In radiographic changes, there is an obvious sequestra, combination of local rarefaction, sclerosis, and periosteal new bone formation. For the left, there is a persistent anemia and elevated ESR. Treatment of chronic hematogenous osteomyelitis. The infected dead bones must be completely eradicated with antibacterial, either systemic and local, or we could also use surgical by sequestrectomy abscess. Complication of chronic hematogenous osteomyelitis is joint contracture, pathological fracture, amyloid disease, epidermoid carcinoma of sinus tract, acute septic arthritis. There is an invasion of pyogenic bacteria to synovial joint. The incidence is parallels that of hematogenous osteomyelitis. It is a disease of childhood and particularly in immunodeficient children. In adults, it could happen in any joint, however, it's not related to osteomyelitis. Etiology of acute septic arthritis involves spread of pyogenic bacteria from metaphysis into the joint. As osteomyelitis, the most common organism is Staphylococcus aureus, or it could also caused by streptococci and pneumococci, less commonly caused by salmonella. In adults, Staphylococci, pneumococci, and gonococci by hematogenous route as a complication of systemic infection. Risk factors such as HIV disease, AIDS, and prolonged corticosteroid usage. Pathogenesis and pathology is an extremely serious infection. Cartilage disintegrate. Granulation tissue may creep over the articular cartilage, an example in penis. there is a permanent damage, pus, that could result in pathological dislocation and particularly in the hip joint. Infantile femoral head is cartilaginous, resulting in complete destruction. And there is also a degenerative joint disease, fibrous ankylosis, and bony ankylosis due to late sequelae. Clinical features and diagnosis in infants. There is a few clinical manifestations such as irritability and reluctance to move involved joint or pseudoparalysis, tenderness over the joint, painful restriction of joint motion, slight fever, white blood cells slightly elevated. There is also immediate needle aspiration of the joint and cramp and culture. In radiographic and ultrasound sonography, there is an evidence of soft tissue swelling. Clinical features and diagnosis of acute septic arthritis in adult. There is a severe pain at the region of the involved joint, protective spasm in the muscle controlling the joint, marked tenderness and effusion, more marked fever, elevated white blood cells count, and erythrocyte sedimentation rate. Needle aspiration is important. We can find that white blood cells is more than 100,000 and is strongly suggestive of septic arthritis. Radiographic, there is subluxation is more common than luxation. There is a narrow cartilage space if the destruction has occurred. Treatment of acute septic arthritis involves surgical emergency, antibacterial drug, pathological dislocation, and residual damage. Prognosis of acute septic arthritis, same as osteomyelitis. If it is inadequately treated, it could be more disabling than osteomyelitis. For the complication, early complication involve death, destruction of cartilage joint, pathological dislocation of the joint, and avian of the epiphysis. For the late complication, there is a degenerative joint disease, permanent dislocation with pseudoarthritis, fibrous ankylosis, and bony ankylosis. Hematogenous osteomyelitis of the spine sufficiently differ from long bones and osteomyelitis. Young children more affected than older children and adults. The most common sites are lower thoracic and upper lumbar. Causative organism is Staphylococcus aureus and Escherichia coli. In children, the first symptoms is poorly localized back pain and protective muscle spasm in the back and local deep tenderness. May involve meninges that result in meningeal irritation and be reluctant to bend forward. For the systemic, there is an irritability, loss of appetite, and mild fever. For normal white blood cells count, however, there is an elevation of ESR. Radiographic examination within the first 2 weeks, there is no bony abnormality, therefore bone scan may be helpful. The most important differential diagnosis is spinal subtuberculosis, and it can be excluded if the tuberculin is negative. Vertebral punch biopsy for confirmation of the diagnosis. In adult, the systemic reaction is more marked. Treatment and prognosis of hematogenous osteomyelitis of the spine is the general plan is the same with acute hematogenous osteomyelitis of bone, bed rest supplemented by cast, operative drainage of the vertebrae, and this space is seldom necessary. In children involved, this space remains permanently narrow. In adults, it is usually fuses spontaneously. Persistent or recurrent back pain due to abnormal segment need local spinal fusion. Osteomyelitis and septic arthritis secondary to wounds. It caused by pathogenic bacteria that have gained access to skeletal tissue directly. Synovial joint is particularly susceptible. The pathological and clinical features are comparable to those of hematogenous osteomyelitis. Careful wound cleansing such as debridement. If infection develops, systemic antibiotics and surgical may be needed. Chronic recurrent multifocal osteomyelitis. It is a series of recurrence and remission of multifocal areas of pain in different sites at different times. No bacteria can be isolated from lesions. NSAIDs are helpful, self-limiting. Pyogenic infection in the hand. Frequently infected due to high incidence of minor hand injuries. Potential serious may spread to bones, joint, or tendon sheath. There are 3 groups involving nail fold or paronica, involving the pulse space of felon, involving tendon sheath. Pyogenic infection in the hand. Pyogenic tendinophysitis. The etiology is portal of entry, laceration, and puncture wound, commonly caused by Staphylococcus aureus. Pathogenesis and pathology. It is comparable to a synovial in the joints. The pus progressively increase pressure. Clinical features. There is a severe local pain, signs of swelling, tenderness, severe pain with passive movement, fever, white blood cells can rise, and also there is an elevation of ESR. The treatment is systemic and local treatment, and also surgery. Necrotizing fasciitis. Potentially lethal soft tissue infection involving dysplasia and subcutaneous fat. It is particularly caused by virulent strain of group A beta hemolytic streptococcus. Antibiotic with radical surgical debridement. The mortality rate is higher than 30%. Meningococcal septicemia, inexorably overwhelming and fatal. Serious complication could result in dead limb. Viral infections, HIV and AIDS. High risk for infection, typically exogenous type of bacterial osteomyelitis and septic arthritis, tuberculous osteomyelitis, tuberculous arthritis, and also various rheumatic disease. Universal precaution. Granulomatous bacterial infection refer to a group of chronic inflammatory conditions, some of which are caused by bacteria and others by fungi. Chronic from the onset, productive element is much more prevalent than exudative element. Direction of the local tissue cells, there is histiocytes including epithelial cells which collect to produce granule. There is more inflammatory reaction progresses, it could form a larger lesion. The general features of tuberculous infections: reduce mortality and morbidity, at least in developed country. HIV or AIDS risk for potentially fatal tuberculosis. Establishment of infection in the past from bovine type tubercle bacteria in milk ingested by children. Principles of anti-tuberculous therapy mainly involve chemotherapeutic agents such as streptomycin, INH, PAS, and rifampicin. The drugs are effective for early lesions. In later lesions are enclosed within A vascular caseous lesion sometimes needs surgical excision of dead tissue and evacuation of the pus of cold abscess. Tuberculous osteomyelitis, always secondary to tuberculous lesions as well in body. Blood-borne infection usually affects children. Tuberculosis, osteomyelitis of the spine. Account more than half of all bones enjoying tuberculosis. The most common site is lower thoracic and upper lumbar vertebrae, maybe from urinary tract tuberculosis from Batson's plexus. Pathogenesis and pathology involve slow and progressive bone destruction, and caseous lesions prevent reactive bone formation and render bone avascular, gradually penetrate thin cortex of the vertebral body. It could also later partially destroyed by tuberculous granulation tissue, and then there is also progressive kyphosis. Pott's disease in clinical features and diagnosis usually happen in children. Back pain, reluctant to sit up, stand up, or bend forward, just like the hematogenous osteomyelitis of the spine. Local deep tenderness, and then there is also protective muscle spasm. For the systemic manifestation, there is a chronic ill health, evidence of pulmonary or urinary tract tuberculosis, then there is also elevated ESR and positive of tuberculosis. Thus, radiographic changes, there is an evidence of extensive anterior destruction, involvement of the vertebrae and paravertebral abscess. Confirmation, we could use aspiration of paravertebral pus. The treatment could be differentiated to generalized and local. For the generalized, we could use the anti-tuberculous drugs, general rest, and nourishing diet. For the local, there's a local rest, turning frame, plaster bed, body cast, direct open operation, there with amount of tuberculous sequestra, evacuation of pus, and anterior interbody fusion. For the complication of tuberculous spondylitis, the most serious complication is Pott's paraplegia. Paraplegia of active disease in early onset, paraplegia of healed disease in a late onset. Less common, rupture to thoracic. Tuberculous arthritis may spread from distant lesion or direct extension from tuberculous osteomyelitis in the epiphysis. The most common sites is the hip and the knee. The onset nearly always in childhood. Pathogenesis and pathology, there is a villous hypertrophy and infusion in the synovial membrane. Small grayish tubercles, tuberculous panus, block the nutrition and then result in cartilage necrosis. Granulation tissue also erodes the subchondral bone that results in the collapse of bones. Cartilage necrosis with the destruction of the underlying bone result in irreparable joint damage. Clinical features and diagnosis usually happens in child, chronically irritable joint, painful limitation of joint motion, proctative muscle spasm, and muscle atrophy. There is an elevated of ESR and also positive tuberculin. In the radiographic, we could see regional osteoporosis, evidence of soft tissue swelling around the joint, also osteolytic lesion in the epiphysis that result in loss of cartilage. For the confirmation of diagnosis, we could use open surgical biopsy. Treatment is with the anti-tuberculous drug, general rest, and nourishing diet. For local treatment, we could use sinupectomy to prevent damage.